Welcome back. This is video number 9, Stent Enhancement Images, Part 1. In these cases, would stent enhancement imaging add any benefits? And in this case, is there a difference between the cine image and the stent enhancement image? In this video, we will answer the following questions. Is there need for routine stent enhancement in all cases? Can we detect the type of the stent in cases of in-stent restenosis? What is the role in ostial and bifurcation PCI? Does it change the plan? And what about long-term benefits? It is important to know when to use enhancement images, the idea, and how to perform a perfect image. Regarding overlap area, if proper view with least foreshortening with all optimum measures, which is discussed later, the distance between the radiopaque marker and the beginning of the stent is seen, if not the same in some types of stents. This will allow for fine adjustment for a least overlap area with a previously deployed stent in the same artery and without a free space in between. With dilatation, there is always some foreshortening of the stent, especially if large diameter. This very short overlap area decreases dramatically the incidence of restenosis and thrombosis. In this 3-year follow-up period study of patients with overlapping stents who underwent target lesion revascularization, 17 out of 25 lesions was in the overlap area. As we can see in this case, two overlapping stents in the RCA with more than 60 mm length. Only the in-stent restenosis occurred in the stent overlap area, which was about 6 mm. Deformity may be seen during positioning of the distal stent under stent enhancement. In this case, there is elongation with density of the distal struts less, with under deployment less diameter of the distal end of the proximal stent was noticed. Also, there was widening of the struts on both sides, denoting stent fracture. Unnoticed calcified plaque may be the cause of this deformity, and the other possibility is balloon manipulation. So, repositioning of the stent was done to overlap all this segment. And this is the picture after stent deployment and non-compliant balloon dilatation with a large overlap segment. This deformity occurred most probably after balloon dilatation of the distal segment and didn't appear with cine angiography. With cine, with some zooming, there is only some under expansion, needing only more balloon dilatation after positioning of the distal stent. There is no appearance of fracture and elongation, which is in need for further stent struts, and there is no appearance of calcium. Both stent under expansion and overlap are significant risk factors for restenosis and thrombosis. In this study, more than 2,600 patients with median follow-up of 2.4 years, the incidence of MACE was about 9.5% if enhanced guided PCI versus 14.4% with standard PCI without enhancement. Regarding stent expansion, under expansion may be seen. In this study, stent enhancement revealed about 20% of underdeployed stents, which was not detected by coronary angiography, and better correlation with IVUS than QCA. Stent diameter and percent of expansion may be measured, yet visual estimation is enough. Due to the high specificity of this finding, there is no need for further intracoronary imaging prior to high pressure post-dilatation. Compared to IVUS, it has 100% specificity, yet sensitivity is low. It can be improved by obtaining two orthogonal views with the beam orthogonal on the long axis of the stents. In this case, the result is satisfactory with RAO caudal view, yet with additional orthogonal view RAO cranial, under expansion is clear and non-compliant balloon dilatation is needed. This low sensitivity is due to longitudinal reconstruction of the stent, which might miss under expansion, while with IVUS imaging, it provides serial axial images. If there is direct contact of an inflated stent with 1:1 ratio on superficial calcium, this is an evidence of a well-apposed stent along the coronary wall. It also correlates well with OCT in detection of underexpansion. In this study, more than 850 patients with 12 months follow-up, stent boost group had significantly lower incidence of lesion revascularization and adverse cardiac events compared with no stent boost group due to detection of underexpansion. The usual cause of underexpansion is calcific plaques. Stent recoil is suspected. Compare the mild underexpanded segment image in the cine with a fully inflated balloon, yellow arrow, with that of the stent enhancement image, red arrows. Hidden suture, green arrow, may also have a rule. Local overexpansion also may be seen. In this case, it barely appeared with haziness in the cine angiography. Usually there is some underexpansion on the other side. Calcium was the cause of underexpansion on the other side. This overexpansion is considered an impending sign of perforation. Regarding aorto-ostial PCI, stent dilatation can be seen in the enhancement images. After balloon inflation of the ostium, there is no deformity of the stent with widening of the proximal segment with normal expansion. Notice the proximal diameter, red arrow, is longer than the distal one, yellow arrow. As said before, ostial venous graft stent under expansion may be due to recoil. A hidden suture, green arrow, may also have a rule. And this is the picture before and after PCI, after enhancement images, with an angiographically acceptable result. Final stent enhancement images may show some fractured struts protruding from the left main ostium. In this case, IVUS images is not useful. So it is advisable to perform enhancement images routinely before removal of the guide wire in any aorto-ostial PCI cases. Stent enhancement images has a very important role in cases of in-stent restenosis. It can reveal number of previously deployed stents and overlap area when cine is not useful. Even several images of several segments could be taken. In this cine image, the middle segment, is it free of stent and is it long or short or a long overlap area? The enhancement image answered the question. It is a free short segment. It also can answer the cause of in-stent restenosis. In this case, there is no description of the cause of in-stent restenosis in CXOM. This is the site of in-stent restenosis segment under focus with cine video. The stent segment appears nearly normal. Yet, with stent enhancement image, it showed a complete stent fracture type 4, as if it is two stents in different directions. This explains the cause of in-stent restenosis, and the plan changes to a new stent deployment, not just non-compliant or drug-coated balloon. Fracture is a rare cause of in-stent restenosis. And in-stent DES should have been deployed. The fracture was unnoticed. This is the final result after non-compliant and drug-coated balloon dilatation. While in this case, the cause was under expansion of the distal segment of the CX stent with extension post-stent. This was documented by OCT. The stenotic diameter 2.3 mm and the reference diameter was 3 mm. So the CX ostium was spared from stenting. Non-compliant balloon dilatation was done, followed by short stent distally with minimal overlap. If If the stent enhancement image is within normal, the cause mostly is hyperplasia or neoatherosclerosis. So, stent enhancement images is recommended before balloon angioplasty in order not to miss other causes of in-stent restenosis with decision of proper treatment. This patient had a CTO in LED 6 months ago. Is there in-stent restenosis? Yet stent enhancement images showed just strut malalignment. Only a non-compliant balloon 3.25 20 mm dilatation was done. Most probably, the malalignment was due to the systolic kink in the LED. Stent enhancement images is also useful in detecting the type of stent. This is very important in case of in-stent restenosis with non-documented type of stent, in order not to deploy the same type again. Views with least foreshortening is taken. All criteria for a perfect stent enhancement, which is discussed later, is taken. Balloon dilatation may be needed for full stent expansion and full strut alignment to evaluate the type of the stent. In this under-expanded segment, no details could be assessed. In some cases, even after taking all the needed measurements, type may not be detected. There is no detailed data of the struts. In cases of resolute onyx stents, the strut peak is directly connected twice per row with no connectors to the strut valley. Relative high opacification due to platinum in the core. While in Zion's family, the strut peak is in same line with the other peak, with a direct U-type connector in between 3 per row. Promus type of stents has the same strut alignment as Zion's, yet due to platinum alloy it is with more radio opacity. Notice the different alignment of the connectors, yellow and red circles, and relatively less strut area. Regarding calcification, notice the difference between the enhancement image and the cine regarding calcium burden and distribution. It is well defined even with absence of stent struts. Enhancement images showed a high calcium burden all along the RCA with several patches. In this case of inferior ST elevation myocardial infarction, there was a high calcium burden in the left system. So calcium was suspected in the RCA subtotal lesion, even if not clear with cine. And due to this calcium burden, the plan was to cover as much as the non-significant calcium plaques in relation to the tight lesion, not just the subtotal segment. Calcium may be the cause of under-expansion on one side of the artery and may predict perforation if with overexpansion. In this study, stent enhancement images was more sensitive than coronary angiography in detecting mild calcifications, 61% versus 55%. Even with no stents, since it is radio-opaque. Both calcium and stents are radio-opaque, so the analysis of detailed data of the stent struts may be impaired in heavily calcific segments. Black arrow. If the calcium is in direct contact with the inflated balloon with 1:1 ratio, it is superficial calcium. If there is a space in between, it is mostly a deep calcium. This is highly important for deciding the line of treatment. Enhancement images is very important in detection of deformities, maybe in the form of under-expansion or longitudinal stent elongation, as in this case of OSTIAL left main. Another stent was deployed on top. And this is another case of elongation of left main LED stent, which may be missed easily with cine. Longitudinal compression may be seen as a line or patches. Avoid foreshortened views for a definite diagnosis. Stent fracture may also be detected in addition to the stent elongation. In this case, there is type 1A stent fracture with single strut fracture, or as an incomplete transverse V gap, type 2 stent fracture. When there is complete transverse with displacement, as if the stent is in two parts with different axes, it is considered type 4 stent fracture. In these cine views, the left main LED stent appears normal. Under expansion may be seen in the cine view in this image. Yet, fracture appeared only with enhancement images. Another orthogonal view is needed to confirm the type. It is type 1B or 2 fracture. If there was no stent enhancement images taken, there would have been non-compliant balloon dilatation due to this under expansion with more progression of the fracture. Regarding bifurcation BCI and the idea and how to perform a perfect enhancement images, this will be discussed in a later video. Thank you for your attention and waiting for your feedback.